to include postpartum psychosis in the DSM-6 when it comes out?
Vaguely.
Vaguely. How vague?
I don't know.
You don't know.
I know that there's question about where it should be categorized and that the DSM is reviewed every time and they try to move things around based on what clinicians and researchers think.
What, if any, impact does the thyroid have on a woman who has just had a baby and is in the postpartum period, whatever they decided it is, 6 months, 4 months, a year? What impact does the thyroid have?
I am not an internal medicine physician. I am a doctor. What I do know about the thyroid is that the thyroid can affect one's mood and anxiety, whether one is pregnant or not.
So is it fair to say that thyroid levels are important in evaluating a woman who is in postpartum?
It's one tiny component of the entire.
Component.
It is one component.
Okay.
Okay.
So what does that mean?
It's one of the.
It's a tiny component. What does that mean?
Okay.
Can you let her finish?
Sure, you'll let her finish. Go ahead.
It's one of the tests that can be done when a patient is admitted.
Okay, was it done by McLean Hospital?
No.
What?
No.
Are you aware that your records indicate that she had a thyroid read that are part of the records?
My recall is that the TSH was not from 2022 or 2023.
Right. It was from 2000 and what? From
I wouldn't know. You'd have to refer to the record.
So in other words, it was imported into McLean records by, I guess, computer access or something from MGH years before, right?
Things move forward, yes.
I'm sorry?
Labs do populate from the past.
Okay, so in the past, as a psychiatrist, as her treating psychiatrist at McLean Hospital, trying to do an investigation, evaluate this woman to tell her what your diagnosis was and what you guys can do to help her out, did you look at the thyroid reads?
It was one of the labs that I would have reviewed.
You would have reviewed. Okay, as you're sitting here today, do you have any memory about what the thyroid reads were?
It was within normal limits.
And that would be coming from how long before? A year, 2, 3?
I don't remember.
So there were no actual thyroid tests done while she was at the hospital at McLean, right?
No.
What is the Edinburgh EPDS or something like that? What is that?
It's a scale.
A scale. What kind of a scale?
It's a postpartum scale for depression.
And it's used by psychiatrists and psychologists to evaluate the risk factor of a woman who is involved with postpartum, right?
I think it's to assess the level of depression.
In a woman who's involved with postpartum, not some guy that got injured on a soccer field, right?
Yes.
So what does the EPDS mean? I'm probably butchering that. What is that an acronym for?
Edinburgh's postpartum depression scale or something.
Okay. The Edinburgh postpartum depression scale. Was that administered to Lindsay when she was in for the 4 days and a half that she was in your hospital?
No.
Why not?
Because we don't necessarily administer scales.
You don't necessarily what?
We don't administer scales.
Why? That's an accepted tool to evaluate a patient as a psychiatrist or a psychologist, isn't it?
It is a tool, but it doesn't, in the end, determine the diagnosis.
Oh, no, of course not, because the doctor who supposedly has access to the person's medical history and all of the other aspects of your evaluation is the one that gives the diagnosis, right?
The psychiatrist makes the diagnosis based on the presentation, the history of the patient.
Right. So far what we've got is a presentation of the patient who was in the locked wards at McLean Hospital, and the presentation was from her, right?
Her presentation is how she presents, how she is observed. It's not what she's telling us.
Well, isn't what she's telling you part of what you consider?
Yes.
Okay. And what Patrick's telling you is part of what you consider?
Yes.
So other than what Lindsay, who is in the locked ward, tells you, and her husband who tells you, what, if any, investigation did you do?
We did not do any additional collateral contact.
And you didn't do any tests either, right? You didn't do it. Did you do a blood test?
Psychiatry as a field is not dependent on blood tests. If it was that simple, it would be much better for everybody. It's based on the evaluation of the patient who's sitting in front of you.
So you're suggesting to this jury that it's not a valid medical step for one to take blood from a person who is on a cocktail of drug medications to find out what their levels are?
No, not a regular procedure at all.
Okay. Now, McLean did not take any blood. McLean did not do the Edinburgh scale, but that would be something that you would be interested in, right, as to whether or not anyone else gave her the Edinburgh Depression Scale.
Let me clarify one thing. McLean did draw blood. They did do testing. There was no testing for levels of drugs. Just
okay.
Let me clarify that. That's
fine.
Okay.
So they took a CBC or maybe a blood count evaluation, but it had nothing to do with what was on board, as they say, as far as tricyclics, antipsychotics, SSRIs, anything, right?
They check for substances of abuse, but nothing else.
Well, there were no substances of abuse in her blood, were there?
No.
How about the tricyclics, the antipsychotics, the SSRIs, the benzodiazepines, the Z drugs that they call some of their categories? They didn't test for that, did they?
Those are not tested on a regular basis.
How about on her basis?
I don't know why I would have tested for those.
Well,
what would have been the indication?
How about if she presents, and the history that she's giving you is that she was on a number of drugs for that 3-month period or 3.5-month period? Would it be of interest to you as to what was on board in her blood?
Medications have different half-lives. So if she had taken something, it would depend on what the half-life was. If it was a day, it would be out of her system. We would not be able to catch it at that time. It would depend on what she'd been taking and, what was in her bloodstream at that point.
So the admission note that was noted in the medical records would be on page 64 of the medical records that you were presented by the district attorney.
I don't remember what page it's on, but
that's understandable. Okay.
Thank you.
Sure, no problem. Can you tell me what I'm looking at? Exhibit 79, page 63. And that would be the record from McLean Hospital, is that right?
Yes.
Okay. Can tell me what this means when it says clinical summary.
That's the social workers note.
Okay. And
Can you, Doctor, can you maybe move that microphone just so that
Sorry about that. That's the social worker's note?
Correct.
And that's what the district attorney was questioning you on? When she referred you to symptomology?
It was just a conversation with Patrick. I'm not sure I don't recall what you're talking about.
All right. You can read along with me, all right?
Okay.
Clinical summary says the case was discussed in rounds, and would that be like on Grey's Anatomy? You have rounds, and they see patients in the rooms and that type of thing. No. What does it mean when it says in rounds?
It's when we meet in the morning. The social worker, the psychiatrist, the nurse, and the charge nurse, the utilization reviewer.
Okay. So that's why it says on page 63, discussed in rounds, SW and PIC met with Lindsay as part of the intake interview, right?
Yes.
Okay. Presenting problem, then it says HX, that's history, right?
Mm-hmm.
And psychosocial HX history was discussed, correct?
Yes.
At that point, she stated that she was hoping to be home by next weekend for her daughter's birthday, right?
Mm-hmm.
And that then she relates her history as far as having a third baby on May 26th. That would be Callan, right?
Yes.
The youngest baby. And she then told you all that 12 weeks after she delivered, the baby wasn't taking the bottle. It was around the time that she was supposed to go back to work. Husband also went back to work, and she was experiencing a lot of, and then someone puts in quotes, situational anxiety. Is that correct?
That's what it states.
All right. So as a result, is that coming from her, or that word situational anxiety, was that her words because it's in quotes, or was that you guys put that in there?
I didn't write that note.
Okay. But you factored that in your investigation, right?
I read it.
Okay. And as a result of this, she subsequently saw a psychiatrist that prescribed her Zoloft, right?
Yes.
And that would be Dr. Tufts, right?
Yes.
And 1 week after prescribing that, it says, after 1 week of taking it, that she developed insomnia, correct?
Yes.
Okay. So that's an indication of a reaction that the patient had to the medication that was prescribed to her, being the SSRIs, Zoloft, right?
It could be a side effect, yes.
Could be, okay. And the psychiatrist told her to stop taking Zoloft, right?
That's what it states.
And do you know from your investigation and your evaluation of Lindsay Clancy, when the doctor told her to stop taking Zoloft? It was like, I mean, you can guess, it was like a week later, a couple of days later?
It would be, if I don't recall off the top of my head, but if that information was available, it would be in my note.
Do you know, can you find your note in here? I just don't know how to navigate that. Would it help you if you had a break or a little recess just to look at this?
No.
No?
I can find it right now.
Okay.
You know, Mr. Redding, that's probably not a bad idea. We've been sitting here, kind of missed that morning recess. So we're going to take that at this point, just a short morning recess. I'll let all of you kind of stretch your legs a little bit, and then we'll come right back. Okay?
Court, all rise. Jurors, close your notebooks. Place them on your chairs, please. This way, please.
Said I should.
Your Honor, can she have permission to take that and look at it, the exhibit, out of the courtroom?
I think it's probably best if you want to look at it, keep that in the courtroom.
Yeah, okay.
Yeah.
All right. So you can look at it, but just you'd have to stay in the courtroom.
Okay? All right.
She wants to take a break, as we all do.
Leave it here. All right, so we'll be in a short recess. We'll come back. Okay, thank you.
just watch your step as you take the stand. Thank you.
We do appreciate this so much. Thank you.
All right, we all set?
Court, all rise. Jurors enter. This court's now in session. Please be seated.
Your Honor, for the purpose of the record, we return back to the trial of Commonwealth versus Lindsay Clancy. All parties are present, including the defendant and including the 18 jurors.
All right. Attorney Sprague?
Thank you, Your Honor. So, Dr. Tufts, back on that first appointment with Ms. Clancy on September 15th, 2022, as part of the record, did you detail a section, history of present illness?
Yes.
And in that section, you put in here initial presentation, nursing school, Prozac helped, got treatment after second baby, 2 for anxiety, Zoloft 1 week, was nervous about breastfeeding, initial side effects. Can you just tell us where that information came from?
My conversation with the patient.
Okay. And where it says Zoloft 1 week, was nervous about breastfeeding, what does that mean?
So she had tried Zoloft before during the postpartum period after her second baby.
And did she tell you whether she had any side effects when she took Zoloft after her second baby?
She mentioned something about initial side effects, which are pretty common for many people. I didn't detail what those side effects were, but they sounded like the very normal ones that people might experience that are transient in the beginning of the treatment.
And what would those side effects be?
Possibly upset stomach, appetite issues.
I apologize. Can we know what related to this patient rather than somebody?
All right, so why don't you ask if she remembers what the defendant said the side effects were?
Do you remember what the defendant said the side effects were?
I don't remember them exactly, but they were ones that did not seem concerning.
And in your experience, in your training and experience as a psychiatrist who prescribes Zoloft, what are the common side effects that you deal with, that patients deal with from this medication?
So in the first couple weeks of treatment, we described that there's a lot of serotonin in the gut as well as the brain. So the medicine often affects the gut first. So you might have diarrhea, constipation, difficulties with appetite, nausea, things like that.
And you also wrote in the note about history of present illness, 3 months postpartum, also 4 and 2-year-old feeling overwhelmed. Is that correct?
Yes.
And that came from the patient, Ms. Clancy?
Yes.
And furthermore, you wrote that the baby needing more attention, other kids more challenging too. Is that coming from the patient?
Yes.
And does she also describe she's having trouble leaving the baby, too anxious to do anything when she leaves, physical tension, heart racing, worries he won't eat or sleep because he's refusing the bottle?
Yes.
And did she say that makes her irritable?
Yes.
And in that same note is where you detail that she denied audio hallucinations, visual hallucinations. You also, correct?
Yes.
And you also detail suicidal ideation, homicidal ideation, denies, no concern about hurting baby. Is the no concern about hurting baby, is that an observation you're making or something that came from Ms. Clancy?
It came from our conversation.
So at some point in time, she told you she had no concerns about harming the baby?
Yes, it was.
I object.
Just an objection? If you could rephrase that question.
What did she tell you about her thoughts about the baby?
I asked if there were those thoughts, and she denied them.
And Did you also provide information to her about what to do if in between appointments there were emergencies or issues?
Yes, I believe that I did. I usually do when I meet a patient.
And in the page describing treatment follow-up plan, which would be in the initial diagnostic assessment from September 15th in that treatment follow-up plan section, there's a part there that says, if having urges to harm self or others, go to the nearest emergency room, call 911, or call the National Suicide Prevention and Crisis Hotline, correct?
Yes.
Is this page given to the patient?
They can access it online on the portal.
So Ms. Clancy would have the ability to go on here, look at the portal, and see what to do if she was having a crisis?
Yeah, just this this plan section, yes.
Just the treatment plan section?
Yes.
So is it that she would have to search through the records, or is that something you can click on to see the treatment plan?
I'm not sure exactly what it looks like for a patient.
Okay. But that's one of the sections that's available to the patient, Lindsay Clancy, if she goes onto the portal?
Yes.
There's also in here, if you feel you're in crisis, you may text home to a certain text number from anywhere in the United States. Is that correct?
Yes.
And what does that do when you text that text number you text home to that text number?
It connects you to a counselor.
Now, what was the treatment or follow-up plan for Ms. Clancy?
To start the sertraline, to start individual therapy, and to follow up with myself.
So your recommendation wasn't just that she take pills, you recommended that she attend therapy, correct?
Yes.
And when you recommended the therapy, did you, and the medication, did you also go over with Ms. Clancy alternatives to the medication that you were recommending?
I believe she was aware that the alternative was that she could not take a medication, which is what she had been doing before.
And after you went over all of this information with Ms. Clancy, did she convey to you that she understood the plan and was agreeable to the plan?
Yes.
What is informed consent?
Informed consent means you communicate with a patient what the risks and benefits are of treatment, and they understand that and they agree to the treatment.
And did Ms. Clancy show that she had informed consent to everything you discussed?
Yes.
Now, was your next appointment with Ms. Clancy on September 28th, 2022?
Yes, it was.
And so during that appointment, did you discuss the medication, the Zoloft, that you had prescribed to her?
Yes.
And what did you learn from Ms. Clancy about whether or not she had taken that medication?
She shared that she decided not to take it.
Did she tell you that she had picked it up but had decided not to take it?
Yes.
Did she tell you how she was feeling?
She said a little bit better.
And did she elaborate on that?
The baby was getting some more sleep, so she was also able to get some more sleep, and that helped her feel better.
And at this appointment, did you go through a mental status exam of Ms. Clancy?
Yes.
And what is a mental status exam?
So a mental status exam is an assessment of the patient at the point of meeting. It can change at different times, but it's comprehensive, referring to how the patient appears, how they cooperate, how they speak, how they describe their thoughts, how they're able to communicate with you, and what their mood is like.
And do you do that at every appointment with every patient?
Yes.
And so on the September 28th, 2022, when you met with Lindsay Clancy for that second meeting, did you do a mental status examination?
Yes, I did.
And what was the result of that?
So I can, is it okay if I read it from the note, or do you just want me to?
There's no objection?
Go ahead, you may.
She was alert, she was oriented, she was appropriate, her rapport, meaning how she worked with me, was appropriate, dressed appropriately, euthymic, meaning not depressed, not angry, kind of a normal mood. Her affect was full, her speech was appropriate, her thought content and a process were appropriate. She did not mention any hallucinations. At this point, I mentioned her insight was poor, her judgment was excellent, her cognition was did not show any deficits, and there was normal psychomotor activity.
And why did you list that her insight was poor?
So I think that must have been related to the fact that at this point, she did have some very clinically significant anxiety. Usually when people come to a psychiatrist, they believe that their symptoms are significant and that a medication is something that might be prescribed. But despite these symptoms, she still didn't want to try the medicine.
And what is the difference between a psychiatrist and a psychologist?
So a psychiatrist is a medical doctor. We go to medical school and then we specialize in psychiatry. A psychologist does not go to medical school. They may do a lot of research in their training. They may learn a lot about psychotherapy, but they don't learn about the human body, about how we metabolize medications and things like that. And so
can a psychiatrist prescribe medication?
Yes.
Can a psychologist prescribe medication?
No.
Now, in the medical records exhibit 219, page 47, it lists here recent lab work, no lab results were found. Is it that you had ordered lab work and you couldn't find the results, or that none were ordered?
None were ordered.
And why is that?
It was not necessary.
And why isn't it necessary at that point for Ms. Clancy to order blood work?
There's no blood work that is commonly done when a patient presents with generalized anxiety disorder and no other medical complications.
What types of situations would you order blood work for?
I mean, there could be a lot. Certain medications require laboratory monitoring, maybe something that, could affect the kidneys or could affect the thyroid, could affect the cholesterol. These are things that we monitor to make sure that the medicine is prescribed safely.
And so Zoloft, is that not one of the ones that would need to be monitored because of its potential effects on the body?
Correct.
And at that time, she reported to you she wasn't even taking it yet, correct?
Correct.
And your appointment that day, I think according to the records, it was approximately 17 minutes long. Is that correct?
So can I explain that?
Absolutely.
Because I think there's a bit of a misunderstanding. So the 17 minutes, I think people are looking at the note where it says a therapy start time of 10 a.m., a therapy end time of 10:17, so they're calculating 17 minutes. But those timestamps are specifically related to the therapy portion of the exam. They're not reflective of the complete duration of time when I met with her.
So what would be the complete time that you met with her on that day?
So I don't know the exact amount of minutes, but the appointments are 25-minute appointments, so it would be more or less a few minutes, about 25.
And so the 17 minutes that are for the therapy portion of the appointment, what comprises therapy? What does that involve?
It really varies based on the person, based on the situation. It can involve, providing some emotional support.
I apologize. Can we talk about Lindsay Clancy rather than in general? That's all.
It's
I'm going to allow a little bit of the background, so that then we'll move into the defendant.
Thank you. So you were saying that therapy portion is kind of talking to the patient, seeing how they are, and getting an assessment of their current mental state?
Yes.
And the other 8 minutes, typically, what happens in those 8 minutes?
That's more focused on specifically medications and medication management.
So these appointments that you had with Lindsay Clancy, when it says 17 minutes, that's the therapy, the talk portion of the appointment, and then there was a separate portion where medication was discussed?
Yes, in the real world, those two segments are intertwined. So it's not necessarily that we say, this is the end of your therapy component. It's a bit more seamless than that.
Now, in your training and experience and the way you conduct your practice, if you're having a therapy portion or you're conducting therapy with a client and that 25 minutes has run out, is it a hard stop or is there an option to continue?
It's not a hard stop. I do have limitations because I have other patients that are waiting. But if there's something urgent, I can go a little bit over. If there's an emergency, I can cancel the next patient if I have to.
And these 25-minute appointments that you have, if a patient were to request a longer appointment with you, is that available?
It's an option.
Did Lindsay Clancy ever request a longer appointment time with you?
No.
Now, that appointment on September 28th, 2022, was that also a virtual appointment?
Yes.
And did Ms. Clancy appear to be alone in that virtual appointment?
Yes.
And based on your conversations and assessment of her on that day, what was the plan going forward?
So at this point, she was improving, and we decided to pause on the medication question and have her meet with one of our therapists.
So that first appointment was on September 15th. You recommended therapy. The next appointment was September 28th. So had Lindsay not scheduled a therapy appointment yet with Jennifer McAllister at that point?
I'm not sure when she called to schedule that.
Okay. And but that was the plan going forward, that your recommendation was that she attend therapy with Jennifer McAllister?
Yes.
And did Ms. Clancy seem receptive to that plan?
Yes.
Did she tell you she was going to make an appointment with Ms. McAllister?
Yes.
Now, according to the records, the next appointment was October 3rd, 2022, just 5 days later. Was there a reason that you had such a short time span between that September 28th appointment and the October 3rd appointment with Ms. Clancy?
I believe that the patient must have scheduled the appointment on her own, and that's why the span of time was rather short.
Do you recall Ms. Clancy reaching out to you about getting paperwork for a maternity leave extension?
Yes.
And did she reach out to you through the portal for Astor Health?
Yes.
And did you respond to her on that portal?
Yes.
And did you fill out paperwork for her to extend her maternity leave?
I think that I did.
And so there is a message from Ms. Clancy to you on September 30th, 2022 in the portal that states, "Hi, Dr. Tufts. Thanks again for all your help at our last 2 appointments. While I am feeling just better enough to function without medication, I did reach out to my employer about extending my leave for reasons of postpartum anxiety/depression. I don't feel mentally well enough to return to taking care of patients with a baby at home that still won't take the bottle. I know this will trigger my anxiety too much, and also having to stay up all night as a nurse, I don't feel it's possible right now. They asked that my provider could fill out a form so they could process this request. Can I please send you the form to fill out? And you responded on September 30th, 2022 at 2:41 p.m. This type of paperwork often requires a lot of information, so it's best if we go through it together in an appointment. Do you recall that?
Yes.
So would that have been why the October 3rd appointment was set up?
That may have been, yes.
And then do you recall receiving a message from Ms. Clancy on October 10th, 2022, stating, "Hi, Dr. Tufts, there is a part on the serious health condition form that you filled out for me that needs to be changed. On the second page, you put I could work a reduced schedule of 8 hours per day, 2 days per week. However, we discussed not working at all until January 1st. I think we talked about when I return to work, that is what I could do, but that the way it appears on the form makes it seem like I can do that now. Do you still have the form to make the adjustment, or do I need to send it back to you?" And then you responded that you would send back an updated version. Is that correct?
Yes.
So do you recall having a conversation with Ms. Clancy at the October 3rd appointment about not returning to work and how long she should be out of work for?
I recall having a conversation about that.
And that January 1st date, was that something you decided or something Ms. Clancy requested?
I think it was something that we decided together.
And in that appointment on October 3rd, did Ms. Clancy tell you that she was on the verge of taking the medication?
Yes.
And did you discuss that with her?
Yes.
And what was that discussion?
Well, she was having more anxiety again. It seemed like maybe it had started getting better, and then it was kind of where it had been when she initially reached out, and so she was feeling like a medication might be helpful.
And did Ms. Clancy tell you at that appointment that she wanted to try therapy before taking the medication?
Yes.
But she had not had an appointment with Jennifer McAllister yet, correct?
I'm not sure what date her first appointment was with Jennifer McAllister.
Showing you page 57 of Exhibit 219, an initial therapy assessment by Jennifer McAllister on October 3rd, 2022. Would that have been the first time she saw Ms. McAllister?
Yes.
So that's on that same day that you saw her. It looks like from the records you saw her at 11:30. Is that correct?
I don't have the time on my paper, but I'm sure that's correct.
Okay, so apparently she saw you about the work form, and then she had an appointment with Ms. McAllister. Is that correct?
Yes.
And it says here in the records that Jennifer McAllister is an LMHC. What is that?
A licensed mental health counselor.
And so is a counselor, a licensed mental health counselor, someone who can conduct therapy sessions?
Yes.
And why is it in your practice that you have a psychiatrist who does therapy and prescribes medication, but in addition, you would have a therapist doing counseling?
So today, a lot of psychiatry is practiced as a team. At least that's how we practice at my office. So oftentimes the therapist is able to see the patient every single week. They're able to focus in more depth on certain aspects of the patient's well-being, and so it's helpful to have one person paying extra attention to the therapy component, especially when the psychiatrist does have to spend a lot of time discussing the medications and thinking about the medications.
And And so is that the teamwork approach that Lindsay Clancy received in her treatment at Astor Mental Health?
Yes.
And in that October 3rd assessment with Ms. McAllister, you reviewed those notes and records so that you could properly treat Ms. Clancy, correct?
Yes.
And in that first meeting with Ms. McAllister, the defendant described her relationship with her parents as very supportive and stable, correct?
I don't have Jennifer's notes in front of me.
Showing you page 60. You want to just review the notes?
Sure.
Look up when you finish. Does that refresh your memory as to the notes that you reviewed from Lindsay's session with McAllister?
Yes.
And so in that session, Ms. Clancy stated that her parents were very supportive and stable.
Yes.
And she also mentioned having the support of an older sister who only lived 2.5 hours away. Is that correct?
That's what she stated in the note to Jen.
Did she also say that she was not close with her in-laws who lived in Scituate? She would see them often as they were her husband's parents, but she didn't generally allow them to watch the children. Is that correct?
That's what I read.
And there's a quote in here, don't have a particular reason why, they don't bug me about it either. Is that correct?
That's what I read.
And October 3rd, 2022, when you met with her that day, did you again do a mental status exam?
Yes.
Had anything changed in that mental status exam from the September 28th meeting that you had with her?
Can I review it?
Yes.
I mean, there isn't anything that stands out to me right now.
And I think that what you put on the October 3rd date was that her insight was still poor.
Yes.
Was that for the same reasons you described earlier?
Yes.
The next time that you saw Ms. Clancy, was that on October 20th, 2022?
Yes.
And what information did you learn on that date about whether or not she was taking the Zoloft you had prescribed?
So she told me that she decided to start the Zoloft.
And did she tell you how long she had been taking it?
For 1 week.
And did she tell you that the previous night she had increased the dose?
Yes.
And that's what was in the original prescription, correct? To take the pills at 25 milligrams for 1 week and then increase to 50?
Yes.
So if that had been done, taking the pills for 1 week would be 7 pills, and then increasing the dosage the next night would be 2 pills?
Yes.
And so that would be 9 pills?
Yes.
When she told you she increased the dose, she told you she now feels awful, is that correct?
Yes.
And what was it that was bothering her?
She was having increased difficulty sleeping. She had loss of appetite, diarrhea. She was feeling her mood was down. She was tearful and feeling very foggy and feeling very anxious.
Now, what is the lowest dose of Zoloft that you would prescribe a patient or could prescribe?
The smallest pill is 25.
And what's the highest dose of Zoloft?
200.
Okay. So she was on the lowest dose of 25, is that correct?
Yes.
And then according to what she told you, she had increased for 1 night to 50 milligrams, is that correct?
Yes.
Did she also tell you she was scared to start something new?
Yes.
Is that in terms of another medication?
Yes.
So what was your discussion with Ms. Clancy when she's telling you that she's having these issues with Zoloft, but she's afraid to try something new?
So we discussed what to do moving forward. So we discussed whether it would make sense to switch to a different medication at that point. And at that moment, because of her negative experience with the Zoloft, she did not want to start a new medication at that point.
At this meeting with her, did you ask her if she had any suicidal thoughts?
Yes.
What was her response?
No.
Did you ask her if she had any homicidal ideation or thoughts?
Yes.
What was her response?
No.
Did you ask her if she was hearing any voices or seeing any visual hallucinations?
I'm not sure if I asked that in that appointment, but she was very clearly not psychotic.
And why do you say that?
Because of how I described some of the signs of psychosis that are on the mental status exam, none of those were present.
Okay. What was her affect during this meeting?
It was depressed.
And did you write that that she was? Strike that. What was it about her affect that made you write that she was depressed?
She visually appeared like she was feeling sad.
And her mood, how did she report that to you?
That was depressed as well and anxious.
What about her thought content and process that day?
That was appropriate.
And her speech?
It was appropriate.
And her judgment and cognitive skills?
Her judgment was excellent, and her cognition didn't have any deficits.
And her psychomotor activity?
Normal.
So the main change here from previous visits was that she appeared depressed and anxious?
Yes.
Although she had appeared anxious that first visit, correct?
Yes.
So to make sure we have the timeline correct, the first visit she appeared anxious, the second visit she appeared to be doing better, the third visit she still had that poor insight when you met about the paperwork, and then this fourth visit she appears depressed. Is that correct?
Yes.
Did she also tell you that she was worried about getting suicidal thoughts?
Yes.
So that would have come directly from her, correct?
Yes.
And what was that? What were the details of that conversation?
So it was one of the things that she was anxious about. It was a fear of one day having suicidal thoughts if she were to continue to feel poorly.
Okay. And showing you page 77, exhibit 219. I know you said earlier you weren't sure if you asked her about audio or visual hallucinations, but just directing your attention to the integral history, if that refreshes your memory.
Yes.
So did you ask her about audio hallucinations and visual hallucinations?
On the 21st, I did.
Okay. All right. So then there was an appointment the following day on October 21st?
Yes.
So why did she have an appointment that following day?
Because she was feeling pretty poorly after starting the Zoloft, so we were following her closely.
And at that point, you knew that she had had an appointment on the 3rd with Ms. McAllister, correct?
Yes.
And do you know whether or not she had followed up making another appointment or was struggling with that? She was planning on making another appointment. I don't know when that second appointment was scheduled. When that first appointment where she was seeming depressed and having issues with Zoloft on October 20th, did you tell her to stop taking the medication at that point?
Yes, I did.
Okay. And did you discuss other options with her other than medication, like natural remedies?
Yes.
And what type of natural remedies did you discuss with Ms. Clancy?
So I mentioned things like fish oils, something called L-methylfolate or SEAM. These are supplements.
And why would you offer alternative remedies to a patient?
So it was because she seemed reluctant to start a prescribed medication. I thought she might be more open to something that was natural.
So you weren't pushing her to take a prescription medication, correct?
No.
Now, on October 21st, when you saw her, did she tell you that she hadn't been able to get any sleep the night before?
Yes.
You've already said she told you she wasn't having audio or visual hallucinations, correct?
Yes.
Did you ask her if she was having suicidal ideation or homicidal ideation?
Yes.
And what was her response?
No.
What was her affect that day?
It was depressed.
And did she tell you during your conversation that day that she had been anxious all day, not depressed or irritable, getting better?
Yes.
Okay, so she's telling you she's not depressed, but her affect to you appeared depressed. Is that correct?
Yes.
And is that for the same reasons you stated earlier, those visual cues that you saw?
Yes.
Did she appear hyper or manic in any way?
No.
Was there any changes in her rate of speech or pattern of speech?
No.
Was there any difference in her mental status exam?
No.
And this appointment, was this appointment virtual as well?
Yes.
Had all your appointments up to this point been virtual?
Yes.
Was she alone in that virtual meeting?
Yes.
What was the plan that was formulated on October 21st?
So the plan was that she start a medication called Ativan to be taken as needed, which means not necessarily every day, but in the instance of severe anxiety.
And how did you explain to Ms. Clancy when to take the medication?
I don't remember exactly how I explained that.
Okay. So in general, as a psychiatrist, when you're prescribing a medication like Ativan and you're telling a patient to take as needed, what does that mean?
So it means when the symptoms are present, and in this case in particular, when the symptoms are severe.
So with Ms. Clancy, what were the symptoms that she was experiencing that made you decide that Ativan would be an appropriate medication?
Anxiety.
So would it be when she was feeling anxious, feeling those symptoms of anxiety, that she should take the medication?
Yes.
And what was the dose again?
0.5.
What's the lowest dose of Ativan you can give?
0.5.
What's the highest dose?
Maybe 2.
Okay. So you started her at the lowest dose, the 0.5.
Yes.
And was there a specific time frame that you wanted her to try this in?
Yes, this was for 1 week.
And was the prescription for a 1 week amount, or is it hard to tell that because it's as needed?
It's hard to tell that without seeing exactly how many pills were prescribed.
And was there also, again, a recommendation to go to Ms. McAllister for therapy?
Yes.
And when were you recommending follow-up with Ms. Clancy?
1 week.
And why a short turnaround at this point?
Because she was still having very significant symptoms.
And did you in fact see her on October 26, 2022?
Yes.
And at that appointment, what was Ms. Clancy's affect?
Depressed.
What was her mood according to her?
It was anxious and depressed.
And did you discuss with her whether she was taking the Ativan and whether it was working?
She said that it was not helpful for her sleep, but it made her feel less anxious.
And in this appointment, there was a discussion of Benadryl. Is that correct?
So she reported that Benadryl was something she had tried and it was helpful. It was taken over the counter.
Had you recommended or told her to take the Benadryl at that point?
I don't think so.
And so when you met with her and she told you that she had taken the Benadryl and it had helped, what was your reaction to that?
I was glad that something was helping.
And did she tell you how often she was taking it or how much of it she was taking?
I don't recall.
Did you ask her that day if she had any suicidal or homicidal ideation?
Yes.
And what was the response?
No.
Did you see any signs of psychosis that day?
No.
Up to that point on October 26, 2022, had you ever had any difficulties in communicating with Ms. Clancy?
No.
And ever any difficulties understanding her or thinking she wasn't understanding what you were saying?
No.
At this appointment on October 26, 2022, did she tell you that she had scheduled an appointment for therapy with Ms. McAllister?
I don't remember. Oh, yes, she did. She said she has an upcoming appointment.
And what was the plan after meeting with Ms. Clancy on the 26th?
So at that point, we discussed trying a new medication because she felt that whatever side effects were caused by the Zoloft had resolved, but she still had the same anxiety that she had had beforehand. So we discussed starting the medication Buspar at 5 milligrams twice a day.
And what is the lowest dose of Buspar?
5 milligrams.
And what is the highest dose you can prescribe?
The pills probably come up to 30 and multiple 30 pills taken per day.
So you could prescribe someone more than 30 milligrams per day?
Like a total dose of 60.
Okay. So you started her again at the lowest dose?
Yes.
And why did you choose Buspar?
So Buspar is very well tolerated. It's a very mild medicine, especially for someone who is experiencing side effects from another medication.
And what does Buspar do?
It lowers anxiety.
And was she to continue taking the Ativan with the Buspar?
She could continue taking it as needed if she were to have those extreme moments of anxiety.
So would it be that the Buspar was twice a day, and then if she felt really anxious, she could take an Ativan?
Yes, because given that low dose of the Buspirone, it might not have been enough of a dose to be effective right away.
And Buspar and Buspirone are the same thing?
Yes, sorry.
There's also a note in here prescribing hydroxyzine 25 milligrams daily as needed for anxiety. What is that?
Hydroxyzine is an antihistamine. It's similar to the Benadryl that she had been taking for sleep. So I recommended that she try the hydroxyzine. It is a safer medicine to take compared to the Ativan. So if someone is feeling very anxious and they can take a hydroxyzine and that prevents them from needing to take the Ativan, that's good. So I wanted her to at least try that option instead.
So you gave her several options on how to deal with the anxiety as it appeared each day. Is that correct?
Yes.
And why take hydroxyzine, which is an antihistamine, instead of just taking the Benadryl?
So they're very similar, but hydroxyzine is indicated for anxiety, whereas Benadryl is really indicated for allergies.
And you discussed this plan with Ms. Clancy, and did she agree to that plan?
Yes.
And in discussing it with her, did you go over all the possible side effects and the interactions of the medications that you had prescribed?
Yes.
And did she voice any concerns about any of that?
No. I mean, I think she was still apprehensive about starting a new medicine and about potential side effects, but nothing specific.
Okay. So it was a general concern about medication in general?
Yes.
But after you had the conversation and explained what you were recommending and prescribing, did she agree to that plan?
Yes.
And was there any change in her mental status that day?
No.
Now, going to the next time that you saw Ms. Clancy, was that October 30, I'm sorry, was her next appointment on October 31st with Jennifer McAllister?
Yes.
So you were able to review in the records in preparation for your next appointment that she had in fact went to a therapy appointment. Is that correct?
Yes.
And the therapy appointment, was that approximately an hour-long appointment with Ms. McAllister?
Yes.
When was your next appointment with Ms. Clancy?
November 2nd.
And on that date, was that also a virtual appointment?
Yes.
Do you know whether the therapy appointment with Ms. McAllister was in person or virtual?
I'm not 100% sure, but I think it was virtual.
Okay. And up to this point, had Ms. Clancy ever told you that she didn't want to do virtual, that she wanted to come in person?
No.
Now, on this November 2nd appointment, did you have a discussion about the abuse bar?
Yes.
And what was that discussion?
So she did not start it. She was too afraid to start a new medication.
Did she tell you that she had continued with the Ativan and the Benadryl?
She said she continued with the Ativan.
Ativan. Was there any further discussion about the Benadryl or the other antihistamine that you had prescribed, the hydroxyzine? I hope I'm saying that correctly.
You are, and I'm not sure. I don't think there was much conversation about the Benadryl or the hydroxyzine.
Okay. And what was her affect that day?
It appeared appropriate.
And what was her mood? How did she report feeling?
Euthymic.
What does that mean?
Euthymic means a normal mood, not necessarily sad or angry or euphoric. It's just kind of neutral in the middle.
And would that have been a word coming from Ms. Clancy or just how you describe the word you used to describe?
It's a clinical word.
Clinical. And did you ask her if she had any suicidal or homicidal ideation?
Yes.
What was her response?
No.
Did you see any signs of psychosis present in her that day?
No.
That day, did you discuss alternatives to Ativan?
Yes.
And why were you discussing alternatives to the Ativan?
Because Ativan was not a medication I intended for her to be taking for a long period of time. It was a short-term medication.
And why is that?
Because it does have a risk of dependency when people take it for a long period of time, and especially at high doses.
So did you bring up this discussion about alternatives to Ativan, or did Ms. Clancy ask about it?
I think that was something I brought up.
And what were the alternatives that you discussed with her?
Remeron, trazodone, pregabalin, and hydroxyzine.
And what was it about those medications that you thought they would be appropriate for Ms. Clancy?
That they might be safer medications that could also help her with sleep, also help her with some of the anxiety.
And how are they safer?
So they don't have that risk of the dependency.
And while you're interacting with her and discussing the alternatives to Ativan, what was her mental status that day? Was there any change in it?
No.
And so after this discussion with her about the alternatives, was there a decision made on how to proceed?
Yes. So we discussed tapering the Ativan by 0.25 milligrams every 2 weeks.
And what does tapering mean?
It means slowly reducing.
And why do you slowly reduce the medication?
So when you are taking Ativan, like I mentioned, the risks of dependency, there's also risks of withdrawal symptoms if a medication like that is abruptly stopped. So that's why we gradually decrease it.
And so if the plan was to decrease it by 0.25 milligrams a week, what amount was she taking per week?
So it was by 0.25 milligrams every 2 weeks.
Oh, 2 weeks, okay.
So at first we were decreasing it from 1 to 0.75.
Okay. So it was a 1 milligram pill that she was taking, and then she would just take less and less and less until she wasn't taking it any longer?
Yes.
Okay. And then had you, with Ms. Clancy, decided on a replacement for the Ativan?
At this point, I don't think there was a medicine that we had decided on.
Okay. So the plan at that point was just to taper off the Ativan, but nothing was added at that point?
Yes.
Did you next see Ms. Clancy on November 22nd, 2022?
Yes.
And do you recall why there was a 20-day gap between seeing her on the 2nd and then seeing her on the 22nd?
Well, I'm not sure. I would really be guessing if I said.
Okay. Did you learn at that appointment on November 22nd of 2022 that Ms. Clancy had started another program?
Yes.
And what program was that?
It was a South Shore perinatal mental health clinic.
And was that the first that you learned of Ms. Clancy being involved in that program?
Yes.
Did she tell you she was thinking about doing it, or that she was already enrolled in that program?
That she was enrolled in it, and that what it sounded like she was going to be transferring her care there.
Okay. And did she tell you that she was starting a new medication?
Yes.
What did she tell you she was starting?
She said she was going to start Prozac.
And did she also tell you that what she was currently using for medication?
Yes.
And what was that?
The Ativan and the Benadryl.
And did she tell you that was for sleep as needed?
Yes.
And so you had put in place a plan on November 2nd to taper off the Ativan, but on November 22nd, she was still on the Ativan. Is that correct?
Yes.
And had she tapered off or reduced the dose, to your knowledge?
I don't have it documented exactly what dose she was taking on that date. She was just still taking the medicine.
Still taking it, okay. On that date, did Ms. Clancy deny suicidal and homicidal ideation?
Yes.
Did she show any signs of psychosis?
No.
Did she also tell you that she was going to be transferring her therapy care to that South Shore Perinatal Health Clinic?
Yes.
So basically at that point, the plan was for her to receive her mental health care at the South Shore Perinatal Clinic and no longer see you? Was that the plan? Okay. Was there also discussion of a return to work letter that day?
Yes.
And did she request that from you?
Yes.
And did you give her a return to work letter?
Yes.
And was that authorizing her to return to work immediately or on January 1st as the previous form had said?
I don't remember what date it was for her to return to work. I don't think it was immediate.
Did you then have a further appointment with Ms. Clancy on December 1st, 2022?
Yes.
And how is it that, she was planning on transferring care to the South Shore Perinatal Clinic on November 22nd, but then on December 1st, she has an appointment with you?
So patients can schedule their own appointments. I'm not involved in the scheduling. I can schedule a patient an appointment if someone asks me to, but they can schedule it without my awareness. So she had scheduled it.
Okay. So she hadn't reached out to you in advance to ask about it. She just scheduled an appointment with you for December 1st, 2022. Is that correct?
Yes.
Okay. And in that appointment, did she tell you that she ended up not returning to work?
Yes.
And what was discussed at that appointment?
That she wasn't getting better.
And in what ways wasn't she getting better?
She had tried the Ativan taper, but without the Ativan, she was having a lot of difficulty sleeping. So she tried a few different medications, a few different medication combinations, but she was having trouble with them.
And did she tell you what types of medication she had tried?
Yes.
And what were those?
Trazodone 50 to 150 milligrams was minimal effect. Ativan and Benadryl combination was helpful. Then she added the Prozac 10 milligrams with the Ativan and Benadryl to help with the sleep, but she still had worse sleep, so that was stopped. Then she tried a combination of Remeron with Klonopin, but she felt disoriented, had rebound anxiety, and it was of minimal help. Then she tried Remeron and Seroquel, and that was prescribed, but she didn't take it.
And these medications that she was talking to you about, those weren't prescribed by you, correct?
Correct.
Did she tell you that those had been prescribed by her provider at South Shore Perinatal Clinic?
Yes.
And what is Trazodone?
It is the category is an antidepressant, but the doses that we use are low, so it's really a sleep medicine.
And what is the lowest dose of Trazodone?
50.
And what is the highest?
It can go very high, up to maybe 600.
Okay. So the 50 to 150 milligrams that Ms. Clancy told you she had taken, is that on the lower end of the dosage?
Yes, it's the commonly prescribed dose, again, because it's mostly used as a sleep medicine. So those are the normal ranges.
Okay. And Prozac, I think you had said earlier, was an SSRI?
Yes.
And that was a medication Ms. Clancy had told you she had taken in nursing school, correct?
Yes.
With no side effects then?
Yes.
And she told you on December 1st, 2022, that the Prozac had worsened her sleep?
Yes.
And then what is Remeron?
Remeron is mirtazapine.
And what's that?
It's another antidepressant.
And what is Klonopin?
It is a benzodiazepine like the Ativan.
So prescribing Remeron as an antidepressant and Klonopin as an anxiety medication, is that an unusual combination?
No.
And then she told you she had been prescribed Remeron and Seroquel but hadn't started that, correct?
So I think she had started the Remeron, but maybe hadn't started the Seroquel yet.
Okay. And did she also tell you that she was having some intrusive thoughts on the Remeron, so she was planning on stopping?
Yes.
Did she tell you what those intrusive thoughts were?
She said it was a feeling like I'm going to die.
Not a feeling that she wanted to kill herself, but a feeling like she was going to die.
Yes.
Did you ask her if she had suicidal ideation?
Yes.
What was her response?
So she denied having suicidal ideation, but she was feeling pretty badly. She said she was close to it, meaning close to having some suicidal thoughts, and that she was feeling very hopeless. But she didn't have any active thoughts of hurting herself, didn't have any intention of doing anything, didn't have any plans.
Did she also tell you, and this is a quote in the records on page 144, "I think it's my problem. I keep reaching out to different people and not sticking with the plan."
That's what I documented.
Okay. And did you discuss that with her, that concern that she kept reaching out to different people and wouldn't stick with the plan?
Yes, I advised that she have one person who is managing the medications.
And why is that important?
so that it's very clear what's happening.
And what is the importance, if any, of sticking with a plan, a mental health plan?
Well, the importance of sticking with a plan. Obviously, the psychiatrist comes up with a plan for very particular reasons. And so, sticking with the plan is advisable.
When you prescribe psychiatric medications, do those medications take effect immediately?
No.
How does that effect start to happen in a person?
Well, it depends which medicine. Some medicines do work very quickly, like the benzodiazepines, Ativan and Klonopin. But the medicines that prevent anxiety, the medicines that prevent depression, those do take a long time to actually kick in.
And why is that?
So the way that the medications interact with the brain, the serotonin receptors, the way that they change the neurotransmitters, it takes time for those changes to happen.
Okay. Now, did you also talk to Ms. Clancy about bipolar disorder that day?
Yes.
And why did you do that? So
it was mentioned because of the poor reaction she had to some of her medications, the insomnia. So we discussed whether these side effects she was experiencing indicated she had bipolar disorder. But when that was assessed, it was not deemed that she had bipolar disorder.
And why was that?
Because she really didn't meet the criteria.
And what criteria didn't she meet?
So there's a number of different criteria for bipolar disorder, or specifically looking at mania, because she did have some symptoms of depression, but the other side is mania. So the most important one is euphoria. So actually 7 days of continued euphoria with very high energy levels. That's the most important one. But then in addition to that, you need some other things like potentially pressured speech, grandiosity, which is like a person feeling superhuman or godlike. You might see increased risk-taking behaviors. Usually those are significant risks, like somebody having affairs or using drugs, things that really negatively impact their life. The person might have a decreased need for sleep, which is not just insomnia, but it's truly not needing the sleep and having enormous amounts of energy otherwise.
What is pressured speech?
It means talking very fast, so fast that it's really hard to interrupt them.
And did you ask Ms. Clancy on December 1st questions that would potentially elicit whether or not she met that criteria?
Yes.
And did any of her responses to your questions indicate any instances of mania in her past or present?
No.
What was the plan going forward from that day?
So at this point, she was still seeing the doctors or the providers at South Shore, and so they were still managing her medications. So the plan was that she had an appointment with them tomorrow. She was considering taking the considering taking the Seroquel without the Remeron because she had side effects with that, but that wasn't decided on. That was something to consider. And we also talked about starting a medicine called lamotrigine. I just gave her some information about the medicine, and we also talked about her going to a partial hospitalization program, which provides extra support for people who are really struggling.
Lamotrigine, is that Lamictal?
Yes.
And did you prescribe it to her that day or just discuss that option with her?
Just discussed on that day.
Why did you discuss that option with her?
Because it was clear that she had depressive symptoms and she was not tolerating some of the other antidepressants. So I thought that might be another option to explore.
And you also discussed with her a partial hospitalization program?
Yes.
And why did you do that?
Because she was really having a hard time. She had, mentioned those thoughts of feeling hopeless and the intrusive thoughts. So I referred her to a program that would provide extra support. It would be a program that she went to every single day, not hospitalized. She could still stay at home and be with her family, but that she would have all-day care every day for, as long as that was needed.
And what program was that you referred her to?
The HRI program.
What does HRI stand for?
It's a hospital. I'm not sure what it stands for.
And where is that program located?
It's in Massachusetts, I think Brookline.
And when you referred her, when you talked about that program with Ms. Clancy and referred her to that program, what was her response?
Well, I gave her the information for it. It's a program where the patient can call and schedule their intake appointment. So I gave her that information.
Okay. And was there any concern at that point? You had mentioned earlier that it's important to have, one provider prescribing medication, knowing what you're taking. You knew she was going to the South Shore Perinatal Program. Was there any concern about discussing medications with her, like Lamictal, on the first, when you knew she was seeing these other providers?
Well, she continued to see me in more of a supportive role, and I was just trying to help her, give her as much information that could potentially be helpful. So it was something for her to discuss with the other providers.
Did you ever reach out to South Shore or to get those records, or ask Lindsay for some type of waiver to get the South Shore records?
No, I didn't. And, the reason why is because she was very aware of what the medications were. She was very able to communicate what the different treatment decisions were. She was very medically sophisticated, so I didn't think it was necessary.
And you were aware she was a labor and delivery nurse, correct?
Yes.
So you were aware she was familiar with medications, and she was able to communicate with you on a level that's not a typical patient, correct?
Yes.
Did you next see her on December 16th, 2022?
Yes.
And did you make that appointment with her, or did she reach out as she did on the December 1st and make her own appointment?
I'm not sure.
Okay. And that appointment on December 16th, 2022, what did you discuss with her that day?
So she was still not feeling well. She said, I'm having a really rough time. She said she found something that was helpful for her sleep, Valium and quetiapine, which is Seroquel. She said it finally works, but feeling very depressed during the day, no motivation, had some SI, suicidal ideation, so she went to Mass General emergency room, declined inpatient. She was feeling hopeless, but didn't have any intent or suicidal plans.
So when she told you that she had had some suicidal ideation, did you ask her specifics about that?
Yes.
And what was her response?
So she described it as this hopelessness, like a fear of not getting better.
Did she have a plan on a plan to kill herself, or a plan of how to kill herself?
No.
And you mentioned she told you she went to Mass General Hospital Emergency Department because of these feelings. Is that correct?
Yes.
And did she tell you that they had offered her an inpatient program at McLean and she had turned them down?
Yes.
Did she tell you why she turned them down?
I don't remember.
Did she tell you about plans? Did she tell you what she was taking for medication at that point in the plans for medication?
She said she was taking a mixture of the Valium and the quetiapine, and there was a plan to increase the quetiapine, but currently she was taking 200 milligrams.
And did she also talk to you about the Women and Infants program in Rhode Island?
Yes.
And what did she tell you about that?
She said that she was referred and appointments were being scheduled.
And were you familiar with that program?
I've heard about it.
Okay. What type of program is it?
It's one of those partial hospitalization programs that I had mentioned, but it is focused on postpartum, so I thought that that was a good fit.
Did she tell you during this appointment that she thought that her depression was related to the Seroquel?
Yes.
And did she tell you why she thought that?
She thought there was some coinciding of the timing in which she started the Seroquel and started feeling more depressed.
And did you note in the records that it was unclear if Seroquel was causing the depression as reported? She was more depressed the last visit before taking it?
Yes.
Can you just explain that, what your observations were?
Yeah, I wasn't sure if the Seroquel was making her worse because she did already seem depressed before she had started the Seroquel. So I wasn't sure. I thought it was possible, but.
What was the plan going forward from that appointment?
So the plan was for her to go to this Women in Infants program, and if she was having more suicidal thoughts, to go back to the emergency room.
And was she also planning to start Lamictal 25 milligrams daily?
Yes, at that moment, given how the depression was continuing and worsening, I did feel like after we had discussed the Lamictal numerous times that I did need to step in and prescribe that for her.
And you prescribed the 25 milligram daily dose for her?
Yes.
What's the lowest level of Lamictal that you would prescribe?
25.
And what's the highest?
So in psychiatry, typically 200, but I mean, it really can go up to 400 or 500.
And so again, you prescribed the lowest dose to start with, correct?
Yes.
And was she to continue with the Seroquel that she had been prescribed by the South Shore perinatal program?
Yes.
And what about Valium?
So I didn't make a recommendation on the Valium. I think there was a plan already in place on tapering it that I supported.
And did you do anything in terms of reaching out to her providers at South Shore Perinatal to let them know you were adding a prescription, or did you communicate with Ms. Clancy about letting her providers know?
I communicated with Lindsay about that, and she was so good at giving me all of these updates about what she did with them. I figured she would tell them when she next saw them.
And did she tell you that she would update them?
I believe so.
Was the next time you saw Ms. Clancy on January 6, 2023?
Yes.
And how did that appointment come about?
So again, I don't often do the scheduling. I'm not sure exactly whether I had scheduled that or she had.
Did you learn during that appointment that Ms. Clancy had just been discharged from McLean Hospital?
Yes.
And what, if anything, did Ms. Clancy tell you about her current mental state and what had happened between your last appointment on December 16th and now this appointment on January 6th?
So she was continuing to feel depressed and attributing it to the Seroquel that she had been taking. So the idea was going to McLean so that she could be safely taken off of the Seroquel.
And was it at McLean, according to Ms. Clancy, that she had tapered off the Seroquel?
Yes.
And so on January 6th, did she tell you what she was prescribed at that time?
Yes.
And what was that?
Trazodone 100 milligrams, Ativan 1 milligram, and melatonin 5 milligrams.
Okay. And are these all low doses of these medications?
Yes.
Did you ask her if she had current suicidal ideation?
Yes.
And what did she say?
No.
Did you ask her if she had homicidal ideation?
Yes.
And what was her response?
No.
Did you observe any signs or symptoms of psychosis in her presentation, answers, or behavior?
No, I did not.
Did you ask her about whether she was having side effects from these medications, the trazodone and the Ativan and the melatonin?
Yes.
What was her response?
So the only side effect she felt was that potentially when the Ativan would wear off, she would take it at night, and then in the morning it would wear off, and she would feel more anxious after it wore off.
And in terms of the trazodone, did she say she had any side effects from the trazodone?
No.
And melatonin, what is melatonin?
Melatonin is a chemical that the brain makes that tells us it's time to go to sleep. It's associated with the circadian rhythm. It's not a prescription, actually. It's a medicine that you can pick up in over the counter at the pharmacy.
And is it just to help regulate sleep?
Yes.
What was her mood, according to Ms. Clancy, on that date?
She was feeling numb.
Numb?
Numb.
Did that cause you any concern?
Yes.
And why is that?
Well, she still appeared quite depressed.
And in what way? Was that her affect?
It was, yes. Her affect was congruent, meaning it was the same as her mood.
Okay. So, just so we can understand, so if if I tell you I'm happy and I appear happy, is that congruent?
Yes.
And if I tell you I'm happy but I appear sad, is that incongruent?
Yes.
And is that important when evaluating a patient?
Yes.
And why is that?
Sometimes it's not congruent, and there could be all sorts of reasons why, but it's just something to pay attention to.
And so on this day, though, her mood and her affect were congruent.
Yes.
Okay. And was there a plan formulated for that day, on that day?
Yes. So the plan on that day was to increase the trazodone to 150 milligrams. She had previously taken that dose and tolerated it well. She had just come off of the Seroquel at at McLean. So we were still in the phase where we were monitoring to see if the depression might get better off of that medicine.
And is that why you didn't immediately prescribe a new antidepressant?
Yes.
Was she to continue the Ativan at 1 milligram per night and the melatonin at 5 milligrams per night?
Yes.
And I believe in this note for under condition, you wrote deteriorating?
Yes.
And why is that?
So it sounds like a very strong word. I will give some context that it's not my choice of a word. I have 3 options when I'm filling that out. I can say a patient is improving, unchanged, or deteriorating. So she wasn't improving and she wasn't really unchanged. She appeared a little bit worse than the last time I had seen her. So the best word is to say deteriorating.
Okay. Was there anything about her presentation or affect, things that she told you that led you to believe that she was in imminent danger of harming herself or someone else?
No, there wasn't. And we had, she was feeling depressed and we had a plan to address that.
Is there something you can do if you have a patient who you think is at risk of harming themselves or others?
Yes.
And what is that?
I could issue a Section 12, which would mandate that they be brought to a hospital for treatment, or at least for evaluation and then possible treatment.
And did you feel that was necessary at that time with Ms. Clancy?
No.
And when you're evaluating a patient, taking the history, looking at their current state, looking at what the answers they give you to the questions, are you reliant on the information that they give you?
Yes.
So if a patient withholds important information, is it hard to make a diagnosis or a plan?
Yes.
Was your next appointment with Ms. Clancy on January 9th, 2023?
Yes.
And what was discussed at that appointment?
So she said that the trazodone increase was helpful. She was still getting that rebound anxiety the day after she took the Ativan. The mood was okay, but she was feeling like she was still flat. She wasn't able to cry, but she said she was able to laugh a little bit, and hadn't been having recent thoughts of suicidal ideation.
Had not been?
Had not been.
And did you also ask her if she had any homicidal ideation?
Yes.
And what was her response?
No.
Did you notice any signs or symptoms of psychosis?
No, I did not.
Did you have a discussion with her about trying an antidepressant?
Yes, I did.
And what was that discussion?
So at this point, she had been off of the Seroquel for a couple weeks, and she wasn't getting better. So I thought that suggested the Seroquel might not have been what was causing depression, and it was depression. So that was what we needed to treat.
And what were your suggestions for treatment of the depression?
We considered some different options. We didn't pick a medicine on that date, but we considered amitriptyline and Wellbutrin.
And Wellbutrin was one of the medications she had taken when she was in nursing school, correct?
Yes.
And you discussed those medications on the 9th. Why wasn't a decision made that day?
Because we had made a different medication change because of that rebound anxiety with the Ativan. We decided to switch that to diazepam, which is Valium, and it has a longer half-life, meaning it's broken down by the body much more slowly, so you're less likely to get that rebound anxiety. And also the nice thing about the diazepam is it's easier to stop gradually. You can every week or every couple weeks, you can increase the dose by just 1 or 2 milligrams. So it's a lot easier to stop. So I felt that that was a better alternative. And she also wanted to be off of the Ativan, so and be able to sleep without that kind of medicine.
And I don't think I asked you this before, but what is rebound anxiety?
It just means that when the medication that treats the anxiety gets out of the system, the anxiety comes back, and it comes back even worse.
And you explained it a little bit, but what is a half-life of a medication, and what does that mean in terms of the body processing it and how it affects you?
Yeah, so it's a little bit complicated, but it's basically the time it takes for half of the medicine to be broken down by the body.
And that tells you or indicates to you how long it lasts in the system?
Yes.
And so you were saying that Valium, the diazepam, the Valium, might avoid the rebound anxiety because it's slower to leave the body. Is that right?
Yes.
Did Ms. Clancy send you, after this appointment on the 9th, January 9th, did she send you emails on January 11th, 2023, asking you about your knowledge and thoughts on ketamine therapy and whether that would be a good option for her?
Yes, she did.
And what was your response to that? If you can't find it, I can bring it up to you.
I think I have it. So I mentioned that it's a great option, but it can be hard to get the insurance coverage for it. Usually you need to have demonstrated that you've tried 4 different antidepressants first, and so that it might be necessary to try another medicine first.
Okay. In that email where she was asking you about ketamine therapy, did she tell you that she was, did she say, I'm still feeling a very low mood, no motivation, just very depressed. This has been going on for months now, and I'm getting desperate for something that would work quickly to get me out of this depressed state. Do you remember that being part of the email?
Yes.
Had she indicated thoughts like that to you before, wanting something that would work quickly to help her feel better quickly?
I mean, she may have said that once or twice.
Do you know where strike that. Did you ever recommend ketamine therapy to you, or is this something she broached to you in this email for the first time?
It was something I had considered because at this point she was starting to be a bit treatment resistant, and ketamine is a treatment for treatment resistant depression. So it's a reasonable thought, but I didn't think we were at that point yet.
And you mentioned that insurance companies usually require you to try 4 antidepressants, is that correct?
Yes.
And when you say treatment resistant, is that someone who is in depression but the typical medications aren't working for them?
Yes.
And did you have an appointment with Ms. Clancy on January 16th, 2023?
Yes, I did.
And what was your interaction with Ms. Clancy on January 16th?
Her mood was still very low. She was still depressed. It was she was able to get out of bed and take care of her basics like hygiene and eating. Her concentration was fine, and she was doing what she needed to do to take care of her baby, though she subjectively felt like the bonding was forced with the baby.
She told you that the bonding felt forced with the baby?
Yes.
Did you ask her if she had suicidal or homicidal ideation?
I did.
And what was her response?
No.
Did she show any of the signs or symptoms of psychosis on that day?
No, she did not.
Did you have a discussion about a Valium taper?
Yes.
And why did you have that discussion? Who brought that up?
That was because she really did not want to have to take a benzodiazepine medication every day for sleep. So we discussed how to come off of that medication safely.
And that, again, is that like taper off to take a little bit less each time?
Yes.
And did she agree with that plan?
Yes.
Was a decision made at that point on which, if any, antidepressant to take?
No, we had not made a decision. Oh, sorry. At this point, we did. We did go ahead and decide to try the amitriptyline.
And what is amitriptyline?
So it is a tricyclic antidepressant.
What does that mean?
It's an older antidepressant that's been around for very many years. It helps treat insomnia and some pain, headache conditions as well.
And the dose that you prescribed, did you say it was 10 milligrams?
Yes.
Is that the lowest dose?
Yes.
And what's the highest dose?
Can get quite high, maybe 150.
And so, again, you started her at the lowest dose. Why was it that throughout this time you're treating her and trying these different medications that you always start at the lowest dose with her?
That's standard practice.